Hi, everybody. I wanted to just share with you an interesting case that had come through my clinic in the last couple of weeks. It was a middle-aged gentleman who was diagnosed with intermediate risk prostate cancer. And after a thorough discussion of pros and cons of treatment and surgery, he elected to undergo a radical prostatectomy. And as you can see in this video, when we were just entering and beginning the case, we noted these small little lesions, these little bumps kind of throughout the peritoneal lining of the pelvis. And so we were uncertain what they were, and there were several of them, so we had a little bit of concern. And so we sent them off for a frozen section biopsy and also surveyed the rest of the peritoneal lining. We didn't see many lesions in the other parts of the peritoneal lining, and so while the frozen section was off cooking, we elected to proceed forward with the operation. The operation itself was very successful. At the time of the surgery, everything was had nicely dissected free of the important structures around it. When we were concluding the case, we did get a phone call from the pathologist that they felt that this was a mesothelial papillary proliferation, not a true mesothelioma. And so we actually did a curbside consultation with one of our surgical oncology colleagues. He had suggested that we resect or fulgurate all visible lesions that we could see, and then we could present the case at our oncology conference and get a consensus as to next best steps. So we did that in addition to resecting all the visible lesions, and there was around 15 or so that we could actually identify. They were very, very small, all 1 to 2 millimeters, but we resected or fulgurated them. We actually formally extraperitonealized the bladder so that if any additional treatment was necessary, it could be contained within the existing peritoneal compartment. As a follow-up, we presented the case at our multidisciplinary tumor board, and we had our surgical oncology colleagues also participate. The consensus was, since we had fulgurated and removed all visible lesions from this individual patient, and since these were formally read on the fixed sections as a mesothelial proliferation that was of low risk for progression, that we were probably safe to not do any significant interventions at this time for this particular patient, and rather monitor him with serial imaging to ensure that none of these lesions recur. And that was communicated to the patient, and I think we're on a good treatment path. So an interesting, unusual case. It's always good to pay attention. When we put the laparoscope into the body at the beginning of these cases, it's always good to do a diagnostic laparoscopy in case you pick up one of these unusual findings. Thank you.